We started a tradition of kind of giving an update as to, where we've come and what's been going on over the past year. We did this last year and wanted to do this again this year. So I will first just to introduce myself. I'm Kate Contois. I'm a psychologist. I'm based in the Department of Psychiatry at the University of Washington, and I am the director of the Suicide Care Research Center. We have a number of our core faculty and staff who will be presenting along with me today and give you an update of everything that we've done over the past year. I did want to kind of give people a little bit of a introduction. This is a picture from our original kickoff back in the pandemic. Was not got everybody there because it was complicated back then. So we are the Suicide Care Research Center. We are a group of clinicians and staff and scholars and advisors from a number of different disciplines. And we also have advisors and participants on our different projects who are parents, who are young adults, advocates, and people with their own connections to the topic of suicide. Our purpose is as a center funded by NIMH, is to improve suicide care for adolescent and young adult patients. We often abbreviate as AYA. These are individuals who are between 13 and 30 years who are experiencing suicidality. We also are focused on their families and their clinicians, in particular in outpatient medical settings. So that would include primary care, adolescent medicine, diabetic care, etc. Our vision is to develop a better model for suicide care that can be used in full or in part by diverse primary care and other outpatient medical settings. So 2025 was a year. I personally am glad it's over. You may have seen this graphic some time ago, maybe last spring or summer, of the delays that a lot of grants faced in the administration's cancellation and delays of grants. So we are one of these dots out here. I did at one point try to figure out which dot is us. I think we're a dot at about this size. And we were delayed in our funding between February and August. So given that our funding is we have about 20, I think it's upwards of 20 staff and faculty funded, at least in part, on this center. It was quite complicated to have to shut down as a center. So we were able to continue. Funding was supposed to come in February. We were able to continue through March, and then the university was just not able to continue to giving us an advanced budget, and we had to stop pay, and that had lots of repercussions. And just before we talk about what we did do this year, which is quite a lot, despite all of this being closed for most of the year, or at least half of it, I just wanted to say some real thank yous. I really want to thank our furloughed staff. I think they were the worst of it, obviously. And they really came back strong and really got us moving again when the funding came back in August, and I deeply appreciate that. I also want to say thank you to our staff who were able to stay on it because we could fund them on other projects, and that meant a lot of jumping around from project to project and patiently facing that we didn't often know, even a few weeks or a month later, whether we were going to continue to have funding for them. I want to say thank you to our faculty who did a lot of bobbing and weaving to keep themselves and their projects moving. A number of these projects were able to keep moving despite this from other budgets, discretionary budgets, etc. I I want to say thank you to our psychiatry research staff, Pam and Allison, and also to to Shelley, our vice chair for research at the School of Medicine, who really had our backs through this and helped us to find some bridge funding to keep things going in the meantime. To all of our advisors and colleagues and friends who supported us through both rational and, I have to admit, to some irrational anxiety, as well as to sadness and a lot of frustration. And I particularly want to say thank you to Julianne and Molly because it was a lot of work. And the three of us just walked it together step by step through trying every strategy we could think of and spending down every penny of our discretionary budgets and surviving pretty endless negotiation and paperwork and reporting. So I really want to acknowledge all of the people who have suffered from this year and who have supported us and stayed really positive and patient despite a lot of reasons not to be. What we're going to do today is to talk. I'll just do a little quick overview of the center in case you're new to who we are. And what we want to do is highlight our different projects that are happening this year. So I will do that. I will then hand it over to the methods core, and Molly and Lucas will tell you some of the highlights of what they've been doing. And then Tess and John can tell you about what we've been doing in our team science and mentorship programs. And Julianne and Jasmine will tell us, talk a little bit about our policy core and those highlights. And we will conclude with our coordinating core and some of the public presentations and other activities that we do as a center. So just to kind of clarify a little bit about who we are. So we were funded by NIMH in 2022. And the goal was to have a transdisciplinary faculty who would work together as a center to come up with, it's really about synergy and coming up with something bigger than its parts. So in our case, this include suicide prevention experts, health services research experts, of whom we have a lot in our department, biomedical informatics experts, and other disciplines who have come together. We've tried to create some new frameworks and concepts and methodologies that will improve suicide care. Again, we always kind of think sort of as a triangle or a three-legged stool, that we really need things to work for patients and their families and their clinicians. The model that we use in our center is the multi-phase optimization strategy, or MOST strategy. And within that, in the preparation phase, because MOST has a three-phase model, the preparation phase is being, what kind of interventions have you developed that you want to optimize and evaluate? And we are using the DDBT Human-Centered Design Framework that was developed at the Alacrity Center here at the University of Washington to create and co-design our interventions. And then we are really focused on optimizing them. In other words, making sure that they're not only effective, but they're efficient and they're scalable and they work for the people who they need to work for before we move out into evaluation in large kind of implementation trials. Our co-design work is really based on this core idea that if nobody likes the intervention, it just doesn't kind of, what's the point? Right? That we are seeing a lot of attempts to implement interventions that are not particularly, they either don't fit with the system, they're not liked by the system, they don't make any sense for the system. So we have really tried to deeply understand the outpatient medical settings that we're in and work with all of these different partners to come up with interventions that will actually work and be able to be scaled. We do work in lots of different areas. So, at our core, we are a research center. So we are co-designing these interventions to improve how we provide care. But we also have a training arm. So we are both training future researchers and their research teams so that to kind of create our next generation of suicide care interventions and next generation of research designs for doing this kind of work. And we're also wanting to bring what we know to clinicians and health systems to improve the healthcare that they are able to provide. And we're doing this in the context of integrating research and policy together in our intervention development. So we are integrating policy makers and the perspectives of policymakers and advocates and other folks working out in the field where suicide interventions are being promoted and funded and shared and scaled, and bringing that into our research and getting those perspectives in our research and generally trying to cross-pollinate between researchers and policymakers. So in terms of this first piece, I'm going to tell you a little bit about about our current interventions, and then I'll hand it off to the methods core for some of our other pieces. The model that we are using is this suicide care pathway model. This is what we see as the experience of suicidal patients as they move through outpatient medical settings. Some risk is getting detected. There's a assessment that needs to happen that leads to some hopefully shared decision making between the patient, their family, and the clinicians on what should happen in terms of short-term risk management. Then there should be some treatment of the underlying issues driving the suicidality, and then long-term surveillance and follow-up when people need it. We believe that there are two core sets of mechanisms that are needed in order for this to work. So the first is that it has to be acceptable and usable. So this is why human-centered design is so central to our work, is if we don't design something that people want to do, kind of what's the point? But we also believe that our interventions need to build on therapeutic alliance, and they need everybody to feel more self-efficacy about managing suicide risk if we're going to prevent unnecessary referrals to the emergency room, or other reasons why care has to get disrupted. We believe if we can build things this way, then there will be more reach. We will be able to scale these interventions because they're interventions that people want and that improve people's relationships in outpatient medical settings rather than creating conflict and anxiety in those settings. And by doing that, we're going to reduce suicidal thoughts and behaviors. So here are our existing studies. So we have a signature study. This is our full-size randomized study right now. We have 3 exploratory projects. They're at about the kind of R34 treatment development level. And we have 3 pilot studies that are 2-year, $50,000 a year studies to kind of develop and do the early work in creating new interventions. And you can see that they span, I've sort of tried to place them here on the suicide care pathway. So you see we have some at the front end of the pathway and others at the far end of the pathway, and we a number in between. So just to give you a little bit of a glimpse at the different interventions we have. Our AMPERE exploratory study, all the way back in the risk detection, assessment, and shared decision making, is developing an app through the Epic chart called Care Companion, or through an external app called MyCap, to better monitor suicide risk and ensure timely intervention by improving the kind of assessment that's done for what is going on with the patient in between sessions rather than just at the appointments themselves. The connections study is in the assessment to treatment window, developing a collaborative narrative approach to suicide care assessment and intervention centered on the patient's story and the drivers that we learn from that story and how we can focus treatment on those drivers to resolve suicidality. The ISSP exploratory study is again at the front end of the pathway, refining and evaluating the Jasper app to focus on assessment and evidence-based suicide prevention for adolescents and families in the outpatient setting. The Jasper's been largely used in the ER context. The WisePath pilot study is adapting a digital app called WisePath to create a supportive set of materials and tools for caregivers and for suicidal young people who are in pediatric primary care. The HOPE study is in this central area of short-term risk and treatment, particularly focused on that window between when the patient has been identified within the primary care environment, but not yet been able to get into a mental health care due to the delays that people experience getting into mental health care. And it's focused on two different things that can be done in that period. One is remote monitoring, and the other is caring contacts. Our large signature project is the SCRC model. This is a model of reorganizing mental health care so that it can respond immediately when patients are in crisis and be able to do a 4-week intervention that has sessions both for a therapist for the adolescent or young adult and a therapist for the caregiver. And they can work together over a month period to assess, manage, and treat the suicidality to prevent an ER admission. And finally, our ASPECT project, which is in the treatment to long-term surveillance period. This is co-designing and refining a teen-delivered caring contact. So the Teen Link crisis line, looking at how they can deliver caring contacts to youth in adolescent medicine. If you are or know somebody who is an adolescent or young adult who has experienced suicidality, or a family or friend who has experienced caring for somebody who's experienced suicidality, we would love to engage you in our work. And we have a kind of portal. You can see the QR code is here, as well as our REDCap link. And Julianne or Macy will put that in the chat for you so that as I click on and hand this over to the Methods Core, you can still have that link. All right, I'll hand it over to you, Lucas.
All right, thanks, Kate. It's great to see everyone today as we start our new calendar year. I'm Molly Adrian. I'm the director of the Methods Core and associate professor at UW in our division of child psychiatry and a clinical child psychologist by training. I'm going to start with presenting our vision for 2026, and then I'll reflect on some of our accomplishments for 2025. Next slide, please. Okay, so as the Methods Core group, we have determined 4 major priorities to build on the years of work that we've already conducted. So the first priority for the Methods Core is to continue to support projects through consultation, intake, and phase transitions. So we're excited to review the new pilot award opportunity in this winter, and then help support the projects that are funded through that award. And we will continue to do phase transitions for STRIBE, or the connection study, from their design build to test, and ASPECT from their discover to design build. And as we are in the latter half of our 5-year award period, we're also gonna plan for our project closeout to make sure that our data can all be harmonized and used to make the whole greater than the sum of the parts. Our second main area that has kind of 3 goals to it is around planning and executing methods core specific aims. And so the first part of that priority is to ensure that we have this cross-institutional repository for medical record data. So this project has been underway for several years, and I'll share what we have done this past year shortly. And we are going to do some testing and replication of making sure that this is working for our SOARS participants. We have over 100 participants in that study now, and so we'll be ensuring that this is functional across Seattle Children's and University of Washington in 2026. We also are focused on our productivity and publications and presentations to reflect our learnings. And so the top 2 writing priorities for our group is to establish a minimal clinically important difference that we could recommend for the center across the Columbia and Haas instruments for suicidal ideation and behavior. And the literature right now, there are a variety of different ways to approach MCIDs. So you can use effect size or standard error, criterion-based or vignette methods. And so through sort of a consensus building process in our group, we have decided to first take an effect size method and evaluate the distributions of the Columbia and Haas from existing data sets and simulate some outcomes reflecting various effect sizes. So we're excited. We think that's going to be a great contribution to both our center and the literature to help us understand change for adolescents and young adults in these domains. The second priority manuscript is to be able to start using this repository of medical record data and comparing it to our survey responses. And so we are prioritizing understanding to what extent the health record captures suicidal behavior in comparison to our survey data, and then really being able to have a clearer understanding about how EHRs can be used to inform suicide risk. So that is writing priority for 2026. And then we're excited to share that our long-term follow-up study that will take all participants in the center who have provided patient-reported outcomes like the Columbia or the Haas and indicated that they're willing to be recontacted. We are going to start that longer-term follow-up. So we were IRB approved at the end of 2025. And we'll be inviting participants to participate in one assessment this year and then another assessment next year. This study is being called the Survey to Extend Research Impact. So I'm socializing that name right now. Thanks for tolerating our name changes. And this is a really important part of the project because it allows us to extend our 2-month data collection window for individual studies to several years, and will inform the overall method center aims in addition to allowing the individual studies to have longer term data collection. Okay, so that's sort of looking forward. And now I'll transition us to look back at 2025. Just as Kate highlighted, it was a extremely challenging year with our study funding and staff transitions and furloughs and the bob and weave And despite this, I think that we have really managed to contribute some spectacular accomplishments, and that is really thanks to the unflappable commitment of our faculty and staff in the center. So the first major accomplishment I wanted to share with you all was that we continue to support studies in progressing. So the 7 studies that are in the center now, we completed intakes and phase transitions for all of them. And through the phase transition process, we've had 6 projects that reported on usability issues and found really a plentiful array of usability issues along the suicide care pathway. So we have 43 documented issues across projects. We are going to be working on ensuring that our coding is that we're borrowing from the Alacrity Center is a good fit for our projects in this year. And we also learned that our data capture is not really getting at broader system issues in doing research on the suicide care pathway in an evolving healthcare context, and some of the challenges in the system integration. So at project closeout, we're going to ask some questions about that just to make sure that we're capturing those higher level issues that are related to the pragmatic work that we're doing. Next slide, please. Okay, another huge accomplishment for 2025 was that we launched our translation process. So in 2024, we had identified our recommendations, process, and procedures for conducting the research surveys in Spanish, Vietnamese, and Chinese. Next slide. And in 2025, we completed this process for Spanish. We started recruitment of Spanish-speaking participants for SOARs, and all core batteries are translated in Chinese and Vietnamese. The REDCap build for Vietnamese is done and undergoing testing by the translation subcommittee for Vietnamese, and our Chinese REDCap build is planned for spring. So this has been a tremendous effort by so many people. I think we have a highly rigorous best practice process in place, but the result has been that it's taken a lot of time. So we're excited to wrap this up and make sure that we can offer access to participate in research for families who speak these languages. Okay, next slide. Another area of growth to celebrate from our year 3 is around our collaboration with ITHS, Biomedical Informatics. So for one part of our informatics methods core subcommittee, we had EPIC programmers complete suicide care documentation and utilize the methods of the center in design, build, iterative methods. And the outcome of this work was to have point of care delivery tools, including a navigator, note writer, smart set, and express lane that are all going to be piloted this winter for clinics that are involved in the depression care pathway. So we're super excited that this work can go live and we can continue to get iterative feedback and really improve what is happening for patients in primary care.
Ollie, can I just jump in with a couple additions?
Yes, please.
Yeah, just wanted to point out that this work on electronic health record integration was not a formal research study. This was like quality improvement work that we were doing within UW Primary Care. And by nature of us being a center and having folks at a variety of different healthcare systems, we've been able to talk about what this integration is looked at like at systems that are not just UW Primary Care. So keep an eye out for, fingers crossed, a presentation at EPIC's UGM conference later this fall, where we're hoping to do a little bit of a comparison across different health systems and ways that they've approached this kind of we're calling it data in around suicide data that actually goes into the electronic health record.
Awesome. Thank you for sharing that. It's a much needed area. I think the like growing regulatory demands and knowing that there is a big gap in what is available for clinicians. This is a great extension of our expertise that can help our UW community. Okay, the final part of informatics work from the past year is around establishing this data warehouse and repository. So in partnership with ITHS and the Seattle Children's Bear Office, we are continuing the repository is built, the structures are completed, a data pull was conducted. To ensure that that the fields are accurate and align with what we expected. And we have a planned manuscript and pilot coming in this coming year. So very excited about the opportunity to use this repository and have a place where our medical record data and survey data can live together. Okay, with that, I'm going to hand it off to Lucas to talk about our engagement work.
Yeah. Hi, everyone. Lucas, I'm the Human-Centered Design Research Scientist at SCRC, and I'm going to talk a little bit about our engagement work with our various communities. So, kind of looking back at why we started to assess our engagement work, this conversation came out of a meeting in November of 2024 with the other, I believe, 7 NIMH practice-based suicide care research centers that are all across the country. And we have ended up sending out a survey to our 6 research projects asking about things like the level of engagement by various groups, how much influence did each of these groups have on the way that the project has progressed, and when did engagement occur. And the hope is that we'll share this information with some of the other research centers and be able to compare across years and see the influence of engagement with our various groups. And this is a picture of those of us that were at that meetup in November of 2024. So some of the key successes and challenges that came out of our first round of this survey, all 6 teams filled out the survey for their engagement in 2024. Teams will be reporting their 2025 engagements at the end of this month. One of the successes was that teams understood that focusing on recruitment was essential and engaging with, in particular, families to understand what they would need in order to participate in studies. Another big part that was a success was the ongoing process of building relationships with clinics through the various phases of the research studies. So in discover, and design, build, and test, there's different needs from clinics at those various stages of the projects. And teams felt that there was success in building those relationships with various clinics. That said, some of the challenges were around limited clinic access and also around hesitancy and clinician buy-in. And I think that's maybe a little bit more reflective of just how busy folks are and how many things are changing constantly. Not necessarily a lack of interest, but more potentially a lack of capacity. Another big logistical challenge around engagement is compensating clinicians for their time. The number of hoops and various regulations that we've needed to jump through and unpack, it's just very complicated to understand how we compensate clinicians for their time. And then while we did understand that focusing on recruitment was important, we still struggled a bit to recruit parents and caregivers to participate in the various studies. So we've got the some of this by the numbers. This is our level of engagement by each of the groups, and we broke this up by patients, caregivers and family members, clinicians, and then the clinics, health systems, and subject matter experts. And you'll see that caregivers and patients tended not to serve in the highest levels of engagement. Um, and I find this to be a helpful pulse check on the level of for our co-design approach. Obviously, this is not a formal assessment, but I think it's worth reflecting what this says about how we structured our center and our studies approaches thus far. And I think it just kind of indicates to us we're doing a really good job of engaging clinicians and health systems. And we're not failing to engage anyone, but there's potentially opportunity to more deeply engage some of those caregivers and patients in projects moving forward. So sharing that as an initial reflection for all of our teams and for any future teams that may want to join the center, something to consider. In terms of the level of influence by group, you'll see again the same groups reflected here. And I think it kind of reflects the same level of engagement and influence of engagement. And then lastly, wanted to just point out timing of engagement here, kind of overlaying our discover, design, build, and test framework. You'll see that this kind of reflects where teams were at anyways over the last year. Many of our teams were in the discover and design build phases. So you'll see more of the studies had their engagement at these parts. And then when it comes to study design, recruitment, and dissemination, these are kind of cross-cutting efforts that happen kind of across the entire lifetime of a project. So it makes sense that these would be higher. More to come on this in a March, I can't remember the exact day, but one of our March talks.
Thanks, Lucas. And I think now we'll toggle over to Tess and John to talk from the team science
And
perspective.
John, I have the slides ready. Do you want me to share my screen?
Yes, please.
Okay.
And you can go to the next slide, I think. Hi, I'm John Fortney. I'm a professor in the Department of Psychiatry, lead the Division of Population Health. I'm also the director of the Virtual Care Query program at the VA. That's an implementation science program. And I'm part of the team science core with Kenya and Tess. Next slide, please. So kind of one of the main functions of the team science core is our pilot grants program. And what we're trying to do with this is bring in new investigators into the field who haven't necessarily done a lot of suicide research in the past. And so we're also trying to get new disciplines involved in the field. So our pilot studies, we require them to have at least two multiple principal investigators of different disciplines. And so we feel that transdisciplinary research approach will result in better research. The pilot studies have to be aligned with the center's suicide care pathway and methodologies that Molly described. The RFA is very specific about this, so we're trying to not only draw new people into the field, but send them down a path that's very consistent with the center. And we are trying to fund pilot studies that will then lead to future successful NIH grants. That's kind of the metric that we're trying to meet. So the pilot studies have to have legs and lead to a future NIH grant application. In addition to funding the pilot studies, we support the dissemination of the findings from those grants. We have 4 cycles of the pilot study program. We fund 2 grants per cycle, and they're R03 level grants, so they're $100,000 over 2 years or $50,000 a year. So it's a pretty nice size pilot grant. And as I said, they all have to have multiple principal investigators from different disciplines. One has to be new to suicide research. We've had 2 cycles already that have been funded. This 3rd cycle, we released the RFA in, I think, September 1st. We expected folks to watch the videos that we developed that explain the center's frameworks and methods. They had the opportunity of getting a consultation with folks from the Methods Corps, but after watching those videos, and the LOIs were due November 16th. We've received 13 LOIs this year, which is the most we've ever received. I'm not sure if that's us doing a better job of getting the word out, or the fact that other funding was shrank last year, and so this was considered to be a really good opportunity, something that was still available. We quickly reviewed those LOIs and invited 7 applicants to submit full applications. Those 7 received written feedback from the Methods Corps about what they could do to improve their application. The full applications are due January 11th. We will have an NIMH-like review section with 3 senior faculty members reviewing each application, giving a written critique using NIH forms and criterias. I'll write a summary statement, and then we will award. Usually we award 2, but we had 1 RO3 drop out, so this year we're going to fund 3 projects. So we are expecting, one of those 7 has dropped out, so we're expecting 6 applications, and we're going to fund 3. Next slide, please. And if you are awarded an RO3, you have some things that support you. We have a monthly seminar that Tess and I and Kenya run. This involves all of the RO3 teams participating in this. It's required. Each team needs to complete a milestone checklist before that meeting, so for accountability, so we can know where they are. We use a rosebud thorn type of format where they talk about what's working in their project, what's not working, and what the future opportunities might be, and we talk about how to overcome any kind of problems, both from a mentor's perspective as well as kind of peer learning. The center has lots of kind of webinars, works in progress, opportunities that they're expected to participate in. With the other Alacrity Center, run by Aaron and Sean, we offer a grant writers boot camp. So when people are finishing up their R3s, they can get help writing that NIH grant. The Methods Corps provides consultation. We have kind of team science resources we provide them. And again, we help them with disseminating their findings. Next slide. Kate kind of went over the 2 projects that were funded in the first round. Sarah Danzo was kind of the star in the first round. She was involved in both of those projects, along with Denise Chang being an MPI of the HOPES project. In the second round, we funded 2 really good projects that both ran into problems. One was funded in the VA, and the young investigator at the VA, who was one of the MPIs, decided working in the federal government was not for him because they made it miserable to do that last year. And so he is about to leave the VA and had to decline the funding. The other one, led by Nicole and Gina, was focused on gender diverse youth, and NIH was no longer funding that research in that area. So they worked with us and Kate to refine, to change that project into a way that was acceptable to NIH and still provided meaningful science. And so we were able to successfully revise that project, and they are now kind of back on board with a slight delay. Next slide. So here's just some evaluation from those receiving the R03s, kind of the things they're saying. They appreciate having access to the experts, especially in the methods core. They like the kind of the practical feedback they get from the monthly seminar about how hiring research assistants, identifying weaknesses in the research plan, and helping address those, helping navigate problems with recruitment, which is always exist. They enjoy networking with others, both the leadership in the center as well as their peers, the other R03 grantees. And they like the monthly check-ins because it holds them accountable and staying on track. And just hearing how other projects are going, what's working, what's not working, how we can fix things, they appreciated that. So I think it's working pretty well. Next slide. Okay,
Okay.
I'll pass it off.
Yep. And Kini Law is the wonderful co-director who focuses on this Collaborating Scholars Program aspect of the Team Science Core, but I'll be covering this. But Kini, feel free to chime in at any point. I know you're in a conference room. So there's kind of 3 programs going within the Collaborating Scholars Program going. We have the Emerging Scholars, which all of the pilot program grantees are invited to be a part of. This is intended to connect trainees and early career researchers from a variety of disciplines with additional mentorship. So they each get a connection to a specific mentor or mentors that can help them advance their career. It also provides more learning and professional development opportunities to support suicide care research and following a career in that path. And then the Advanced Scholars, which we just sort of recently launched, is meant for more experienced and senior investigators from a variety of disciplines. And this is an opportunity for them to collaborate with the Center to advance interdisciplinary suicide care research. And also kind of new is the Visiting Scholars. And this program is where other experienced and senior investigators that are more outside of the UW system or outside of the regular center collaborators would be able to visit our center and meet with people and discuss their research. So for the Emerging Collaborating Scholars, we currently have 13 emerging scholars in the program. They're from a variety of disciplines, including psychology, internal medicine, psychiatry, pediatrics, human-centered design, public health, and social work. And we actually have 2 current applications, so it's probably going to be 15 emerging scholars in the next month. We started a quarterly seminar series in addition to that monthly pilot grantee seminar series, and that started in December 2025. Our first session was on how to build and sustain strong mentorship relationships. We have 4 more webinars planned throughout the year, including building collaborative networks and teams for grant-funded projects, grant rating for NIH and other funding sources, project management for research projects, and then 1 more, which might be a wrap-up or some other topic, depending on what people need at that point. And we are currently still accepting and reviewing applications. So if you are interested in this, there's a QR code, there's a link. Feel free to share with people that you think would be a very good fit for this program. And so for the advanced scholars, we currently have 2 advanced scholars. One is Laura Richardson, who's in pediatrics over at Seattle Children's, and one is Stephen O'Connor, who's a psychologist who also was working at one of the NIMH P50 centers. And so these are going to be collaborating more with our center in general because they're more experienced and can provide us some support as well. And then for visiting scholars, we have 2 visiting scholars currently lined up. One is an IRI research fellow who will be visiting in February. So we're working on planning out who they're going to talk to, what talks they're going to attend on our end. And then also we have someone from the UK who has a National Institute for Health and Care Research grant, who will be visiting in either March or April. So we're very excited to have these guys show up in the next year. And one other aspect of what we're doing is we're hoping to start a monthly book club at the end of this month or close to. And the plan is to read Pat Aryan's new book, High Quality Psychosocial Interventions Research from Conception to Piloting to Population-Based Trials. Some of you may have read an earlier version of this that was published a few years ago, but this is the 2nd edition. It's expanded. It's got all sorts of new information for how NIH grants and other such things are run now. This will be open outside of the Collaborating Scholars program, so all Collaborating Scholars can attend, as well as SCRC, CSPAR faculty and staff. And if you have any grad students or other trainees that would be interested, we're going to open this up to a fairly broad pool. And more info on this to come in the near future, probably in the newsletter this month. And that is what we have.
Thanks, Tess. And John, I'll go ahead and take over the share now. We're doing lots of dancing between screens. It's going pretty smoothly, I say. And it's still working. Okay. Well, that was our team science core talking about sort of the training and support dimension of our work. I'm Julianne Salisbury, manager of SCRC. And I'm going to talk a little bit about the integrating intervention development research and policy work we've been doing with our policy core. Here's all the lovely members of our policy core. Um, this last year, one of our big successes in partnership with the Methods Core was to publish this manuscript entitled Partnering with Policymakers to Design Suicide Care Research. In it, we discuss trends in suicide care policy and funding structures. We provide some recommendations around advancing research translation into evidence-based policy decisions. And then we also provide recommendations for researchers to incorporate policy perspectives into the development and evaluation of those interventions. And then we talk a little bit about us and how we're doing that. Um, and one of the dimensions of that we explore is our contextualizing panel meeting discussions, which I'm going to invite Jasmine Swanson, who helps to coordinate us around these, to talk a little bit about what those have looked like and will look like this year.
The contextualizing panel discussion meetings are one component of policy cores. Aims, we are hoping to get all of our project teams into one of these meetings where we have our lived experience panel and our policy, finance, and outpatient medical network experts join these meetings and give feedback on specifically the interventions for our research teams, with the goal of helping our research teams stay aligned with their interventions being able to fit into the real world and also communicate with policymakers. We are kicking off the year with a contextualizing panel meeting in January. It's going to be on the 21st. We actually have a couple of our contextualizing panel meeting members in the audience today. And we'll have Stripe and Ampere. They will be the first to present at these meetings, and they'll get some personalized feedback from both our lived experience and policy finance healthcare folks. We also will have two additional meetings this year, one in May and then one in September. And those meetings will have either one of our R34s or our R03s present at those meetings as well. We're still getting that figured out as far as who will be presenting and what spot. Last year, we kicked off the year with our first contextualizing panel meeting ever, and that went really well. We invited all of our research teams to join that meeting, and everyone introduced the projects to our contextualizing panelists. So this year, we're hoping to allow teams to have a lot more time with our contextualizing panelists to get more personalized feedback.
Great, thank you. And recognizing the time at 9:57, I'm just gonna zoom out briefly, talk about some of the coordinating core successes, and then also just let people know about some of our trainings. So just to peek back at our SCRC organizational structure. So you've heard from Molly about the methods core. We've heard from Tess and John about the team science core. We briefly touched on the policy core activities, and then Kate had sort of given a quick overview of all of our current research projects. And that leaves the coordinating core right here in the middle. We're sort of the behind the scenes core, doing a lot of organizing, cross-pollinating, setting up some of our DSMB meetings, advisory board meetings, and just general operations. So not a ton to necessarily report out on, but want to acknowledge the members of our coordinating core team. Kate, me, Macy, Tess, and Jasmine, and we're hopeful to be able to hire additional support here in 2026 because we have lots we still want to do. I don't think I'll read through all aspects of this slide, but a considerable amount of our time in 2025 was sort of reorganizing ourselves after our center pause. And despite that, we were able to successfully host a well-loved training around suicide care and healthcare systems, which I'm just going to jump to for time. I just wanted to celebrate it. So it was successful. We had 142 clinicians ranging from behavioral health providers to pediatricians to nurses attend. And overall, great rating, very good or excellent. 90%, 98% of folks who completed an evaluation agreed that that was sort of the quality of it. I added this little quote, looking forward to future trainings based on the quality of this one. And then I just needed some more feel good. So I took more quotes about people's experience on these trainings. People really like the format, really appreciate the expertise of our presenters. And so we are really looking forward to being able to offer this again in 2026 live training. We're offering participation in this training for free to any SCRC affiliated clinics. So anybody participating in any of our research studies or folks who are on our advisory boards or contextualizing panels, we invite you to come and check out what this 2-day, 6-hour training entails. So you can keep an eye out on our mailing list for when that registration opens. It is 10 o'clock. So thank you, everybody. It's been a year and we're excited to kick off a new one. I think Macy will plop in the chat an evaluation for today. Any closing words from anyone on the team?
Just happy to see everybody who's able to come and join us today and hear about what we're doing, and we really look forward to seeing you again as we have each of the first Wednesday at this time, 9 Pacific, noon Eastern, when we host these public meetings, and we hope to see you again.
Thank you.
Thank you.